going to move into a special session, which is the Pathology Mimics Workshop. I'm glad to introduce Dr. Karen Rech from Mayo Clinic Department of Pathology and Dr. Jennifer Picasic from Cincinnati Children's Hospital. I took the liberty to add a subtitle there, Tissue is the Issue. Okay, we'll have Dr. Picasic present first, followed by Dr. Rech.
Okay. All right, so we're going to talk about BRAF V600E and the pediatric brain, fine line between GXG and Erdheim-Chester disease. So I always like to bring back a sort of intro that, when we talk about this sort of xanthogranuloma family of lesions, it's wide and diverse, both in the histologic subtypes as well as clinical phenotypes, as you all are well aware. And within that group, we definitely know, of course, ECD is distinct based on the radiographic and clinical molecular, but under the microscope, it looks very similar. Same with ALK histiocytosis, which we now know is a specific subtype. So just some examples to get us started. So this is a classic case under the microscope, would look like a reticulohistiocytoma with this very oncocytic cell type. But what was interesting in this case is that this was BRAF V600E mutated. Oops, lost the. Okay, and the last picture that this lady had subsequently developed other symptoms, and further imaging did show that she had retroperitoneal fibrosis and had this more classic look for ECD with foamy histiocytes. Now we see other cases with a more sort of vacuolated cytoplasm, and even in cases in the liver with expansion in the portal areas with a more sort of epithelioid look. This can be in classic hepatic infantile GXG, but we've also seen such cases in ALK histiocytosis. So many different subtypes within this group. And again, it's more of this sort of clinical radiographic and molecular that's sort of helping define in a little bit better detail than what we can do under the microscope. And that's shown here. So the first case that we're going to present, this was a young 4-year-old female, and she had a hospitalization with ataxia and tremor and some speech changes. And it was also noted that she did have a skin little lesion that was subsequently biopsied. But on the MRI, they did note that not only did she have these multifocal enhancements that were in the right frontal lobe and brainstem and cerebellum, that there was also this very notable T2 hyperintensity. And for many of us in the room, these features looked very reminiscent of what we know in LCH of sort of neurodegenerative type disease. But in a pediatric setting, this wasn't sort of thought about at all, and they were very concerned about these white matter changes of whether this was an inflammatory or genetic type background. And they did send out mitochondrial testing because they just couldn't figure out what was going on with that white matter changes. But at that time, they did luckily put a needle in to the enhancing area and lesion. And it was a diffuse infiltrate that under the microscope, the pathologist was, concerned about these being histiocytes. They are sort of plump and epithelioid, round nuclei, some with a Teuton giant cell like morphology, not really significant nuclear atypia that you would be concerned about for a malignant lesion. And with further immunophenotype that we subsequently did show that it conformed well to that JXG immunophenotype with a nice strong surface and cytoplasmic of CD163, surface staining for CD14, and a nice granular CD68 staining with factor 13A that we also use in our panel, having nice cytoplasmic staining. The proliferation index was quite low, and the CD1A and S100 staining was negative in the lesion. But what was fascinating was that when we did the BRAF mutant specific BE1 immunostain, showing that all these cells had very strong and diffuse cytoplasmic staining. So this was confirmed with further molecular testing. And at that time, we put as a diagnosis that this looked to be in that JXG family of lesions, but with the caveat of the BRAF V600E. And whenever, more so with adults, if I ever see something under the microscope that has that sort of xanthogranuloma look, I always say that this needs further correlation with clinical and radiographic findings. But in pediatrics, we don't usually do that, right? The incidence, as we know, is very low for ECD in pediatrics. But in this case, given the BRAF V600E mutation, as we know, in run-of-the-mill JXG lesions, we do not find that mutation. So in further follow-up, they did biopsy the skin lesion, and it was also shown, at least by the immunostain, to be positive, but there was no other systemic findings at all to suggest any classic adult findings of ECD. Not surprising to me, but the mitochondrial testing that they were adamant about sending was negative. And this patient started on therapy with fludarabine and initially had a favorable improvement, but the white matter, that T2 hyperintensity changes were not fading. So they decided to add a combination of both BRAF and MEK inhibitor. And there was clinical improvement. So they decided to just keep on with the combined targeted therapy for one more year. And clinically, she did well. And at that time, after that third year of treatment, they decided to stop medication and see what the clinical aspect would be. But about 3 months later, she did start having worsening clinical signs, and they decided to restart the combined therapy, with no surprise to most of us here that her clinical symptoms and signs started to improve, with the exception that even most recently, just a couple months ago, that the MRI still has this sort of stable pattern of neurodegenerative changes, but no new enhancing lesions. So this was a case that we had highlighted in our small series of the pediatric CNS JXG lesions, of which half of them did harbor the BRAF V600E mutation. And of those 5, there was only one that had the sort of classic, by the definition of our understanding of adult ECD, with having that sort of definition. That patient they'll sort of show next to highlight. But in a case like this, with basically CNS type disease that was aggressive, with both enhancing lesions and white matter changes in this single cutaneous lesion, does this represent a unique form? It certainly is different than the typical JXG, cutaneous JXGs that we see. So still unanswered questions. And also of note that we had at least another 1 or 2 kids with some associated white matter change disease. And as we know in LCH, the BRAF V600E in the brain with the neurodegenerative disease, it does portend, it seems, a more aggressive course. So as we know, there are case reports of true classic pediatric eartime chest disease, and one of the kiddos in the series was one of those classic cases, and in similarity, but difference with the MRI imaging. This kiddo had a more dural-based tumor burden with some extension into the cavernous sinus and the suprasellar regions. And on pathology, he had a more typical sort of xanthomatous look with a nice Teuton, classic Teuton giant cell present with the typical immunophenotype. But at that time, and this was sort of early on, he wasn't molecularly confirmed right at the bat, and had subsequent treatment failures as listed below. And it was then with the correlation with the molecular, and showed that this was in fact mutated with the BRAF V600E, and subsequently found to definitely have the bilateral sclerosing lesions in the bone. He went through progressive surgical and other clinical treatments of avail, but with Eli's group, this was also published by them, had some improvement with the anakinra. So in sort of short brief, this is sort of how I approach the JXG CNS type neoplasms. So upfront molecular testing is a must in these. And I tell pathologists and the trainees all the time that these should be treated just like any other CNS tumor lesion. You can follow the sort of what the WHO classification is giving a sort of preliminary histologic diagnosis. And I think that, it's still fine to have that sort of preliminary as a xanthogranuloma-like family lesion, but with the integration of molecular, it's very important, because we also showed that a lot of CNS disease with a non-LCH phenotype can also harbor the ALK fusion. So I think it's important for the pathologists to put their mindset into, okay, we have a histologic diagnosis, this needs integrated with molecular, and then up to the clinical team to further integrate with the pathology about the clinical correlation, because, there does seem to be a difference between some of the pediatric JXGs in the CNS versus, whether this really represents a more systemic ECD-like disease. Oops, I just went back, sorry. And that's all I have. Thank you. I think we should wait for questions.
Yeah, we'll have Dr. Rech go next. Dr. Karen Rech from Mayo Clinic.
Good morning. I'd like to thank the ECD Global Alliance for allowing me to present pathology today to a clinical meeting. So I'm going to talk about ECD involving the lung today. And I'm going to first present a classic example of a biopsy from a lung biopsy from a patient with ECD. And then I will show two examples of lung biopsies that were diagnosed on pathology originally as ECD, but turned out to not be the case. So ECD in the lung is fairly frequent. It has been reported to be present in 35 to 50% of ECD patients. It has a lymphangitic distribution in the lung involving the pleura and the interlobular septa. It has less pronounced perivascular and peribronchiolar involvement, which is in contrast to pulmonary LCH, which does tend to have a more peribronchiolar pattern with stellate fibrosis. The infiltrate in ECD is composed of histiocytes with eosinophilic or foamy cytoplasm. There can be some different morphologies to the histiocytes, as Dr. Picasic has already talked about. And it's associated with variable amounts of fibrosis and usually minimal chronic inflammation. The differential diagnosis for this pattern in the lung includes interstitial lung diseases, including usual interstitial pneumonia and nonspecific interstitial pneumonia, Rosai-Dorfman disease, and Langerhans cell histiocytosis, as well as other nonspecific inflammatory drug reactions. So this first case is a classic example of ECD involving the lung. There's a 71-year-old man presented with idiopathic pleural effusions occurring over several years and shortness of breath. Imaging studies showed diffuse bilateral pleural thickening as well as some pericardial thickening. He had small bilateral pleural effusions that extended into the major fissures, and he had diffuse bilateral irregular interlobular septal thickening, more prominent in the lower lungs, as well as diffuse ground glass opacities throughout most of the lung parenchyma. So an open lung biopsy was performed. And on the left, you can see an H&E image, a low power image of the lung biopsy. I don't know if, can you see my cursor on the screen? Yes, okay. So this is the pleura here. You can see it's quite thickened, goes from here to here. And then there's also thickening of these interlobular septa, you can see here. That's highlighted even more on the stain for 163, CD163, which stains histiocytes. You can see in the pleura, there is an enhancement of histiocytic infiltrate in the pleura, as well as along the septae here. You also see these collections of histiocytes within the alveolar spaces in the alveolar parenchyma here, and those are the pulmonary macrophages. So additional staining was done. This is a factor 13A stain on the left, and you can see that it shows a similar pattern to the CD163. So those histiocytes involving the pleura and the septae are positive for CD163. The cells within the pulmonary macrophages, in contrast, don't show a lot of staining for factor 13A. Cyclin D1, this is a low power view, and so I apologize, it doesn't show up as well as I had imagined. But you can see, and we'll look at higher power, but you can see that in the septae and in this especially subpleural infiltrate here, that there's increased cyclin D1 staining. Looking at higher power along the pleura, you can see that it's very thickened, and it's thickened probably more from edema rather than fibrosis here. And we have this infiltrate of histiocytes that are 163 positive, concentrated more at the subpleural surface here. And looking at higher power on the factor 13A and the cyclin D1, we can see that these cells are positive for factor 13A. And here we can see better the cyclin D1 expression, overexpression in these histiocytes here at the base of the pleura. And you can see that in the pulmonary macrophages, we don't see cyclin D1 overexpression. Higher power yet, we can see that the histiocytes in the subpleural areas have kind of an epithelioid morphology here with dense eosinophilic cytoplasm, CD163 positive and factor 13A positive. And here we see the cyclin D1 overexpression here, and we see it both in a nuclear and cytoplasmic pattern here. Here is an example of a focus of imperipolesis. You can see that there is an engulfed lymphocyte here that's highlighted by the cyclin D1 stainings around it. Looking more closely at the septal areas, you can see that the septal areas have more fibrosis compared to the pleura, as evidenced by this more pink background in the stroma, but again has a pretty intense infiltrate of histiocytes. On the factor 13A, we can see that there is a lot of expression of factor 13A here. However, compared to the infiltrate in the subpleural areas, the cyclin D1 is more weakly and has a more patchy staining pattern. The cyclin D1 staining here is actually, these are pneumocytes. These are epithelial cells here that are staining. Looking at those septa with other stains, S100, CD1A, and Langren were also performed and were negative. Those are not shown Here we have a high-powered view of an OCT2 stain, which is a stain that's positive in Rosai-Dorfman disease, and you can see that that's negative here. This is some anthracotic pigment. And the BRAF V600E mutation-specific stain using the VE1 clone was also negative in this case. So I'm going to talk a little bit further about that case. So that was classic for ECD. By pathology, the VE1 stain was negative, so indicating that it did not have a BRAF V600E mutation. In pathology, I would recommend NGS to confirm a mutation before actually giving a diagnosis, a definite diagnosis of ECD. So in this case, I did not have that information, but I asked one of my colleagues in molecular hematopathology 1 week ago today to see if he could get me NGS studies on this case. He sent me an email about an hour ago saying that he did identify an activating point mutation in MAP2K1. So it is a bona fide case of ECD. So moving on to case number 2. This is a 43-year-old man who presented in 2019 with 1 to 2 years of shortness of breath, fevers of unknown origin. He does have a long smoking history, and he also had some workplace exposure to cement dust and a prior biopsy that had shown some patchy organized pneumonia and a possible focal dust macules, suggesting maybe a silicosis or some sort of pathology like that. The CT scan in 2019 showed bilateral central lobular ground glass opacities with an upper lobe predominant emphysema, probably related to the smoking, and an open lung biopsy was performed. On the left, you can see that the H&E shows this is the bronchial epithelium here, and this is septae of the lung, and you can see it's widely thickened by this infiltrate of histiocytes that are CD163 positive. And there's also an increase in pulmonary alveolar macrophages. So on IHC, these cells were negative for S100, CD1A, and Langerin, which is important, particularly given his smoking history and the association with pulmonary LCH. A factor 13A stain was interpreted as positive, although in retrospect, it shows more sort of pale cytoplasmic staining without nuclear staining, which in a true case of ECD, usually you should see both nuclear and cytoplasmic staining. And the cyclin D1 stain is negative. Again, you can see that the staining pattern is kind of similar to the factor 13A, so probably both of these stains should be considered negative. At that time in 2019, an IHC using the VE1 clone was performed, and with the results shown in the image. And you can see that the histiocytes within the septae, as well as some in the alveolar spaces, show this strong cytoplasmic granular type staining for the VE1 antibody. So this was called consistent with ECD in 2019. The patient was treated with vemurafenib, and over the next year, I think he was treated about a year, he showed minimal to no response to that. And so after about a year, he had a rebiopsy of the lung, and it showed similar findings with similar staining pattern for the VE1 IHC. And so additional studies were investigated. So molecular studies were done, which had not been done initially. NGS was completely negative for any pathogenic mutations, suggesting that this was not ECD at all. Digital droplet PCR was negative for BRAF mutations, V600E and K, in case you thought the NGS maybe didn't pick it up. It was proven to not have the BRAF mutation by both methods. And so it's not clear what the diagnosis is in this patient. However, I think it is clear that the IHC result was false positive. And our hypothesis for what caused this was that the VE1 clone is known to cross-react with axonemal proteins present in cilia. At the upper right of this picture, you can see the cilia of the respiratory epithelium staining strongly for the VE1 stain. and that's known to occur because of the ciliary protein cross-reactivity. And so the staining out in the histiocytes, it truly was in the cytoplasm of these histiocytes, and it's not clear what is causing that, but a theory is that there could be sloughing of the respiratory epithelium, and then the histiocytes are engulfing the ciliary proteins that are coming off of the sloughed epithelium. So that's case 2. Case 3, moving on to another pathologic mimic of ECD, 64-year-old woman with a diffuse rash since 1994. She had some biopsies of the skin that were reported as granuloma annulare. She had chronic sinusitis. She had an elevated SED rate. She had a prior bronchial biopsy that that was reported as non-necrotizing granulomas, and so a diagnosis of sarcoid was considered. She really was asymptomatic in terms of respiratory symptoms. CT scan showed bilateral pulmonary ground glass opacities with interstitial prominence in areas of nodular consolidation. She also had mildly enlarged lymph nodes in the mediastinum, iliac, and inguinal sites. So an open lung biopsy was performed finally in 2003. Here's a picture of the lung biopsy, and you can see that there's sort of nodular collections of cells within the septae, and also in peribronchial areas here, with some areas of relatively normal alveolar parenchyma. So it has a lymphangitic, perivascular, and peribronchial distribution. At that time, stains were done for CD68 and S100, and they were reported as positive for both. So it was considered most consistent with ECD. Because the patient was asymptomatic, clinical observation was the course. So then in 2014, imaging showed persistent lung and pleural disease, as well as bilateral perinephric soft tissue masses with stranding of the fat, and bone involvement in the proximal tibia and feet. So at that time, the workup included urine cell-free DNA testing for BRAF V600E, and it was reported as positive. So she was treated with vemurafenib and had minimal response. So the lung biopsy from 2013 was called for second review, and looking at higher power on these interstitial infiltrates, you can see that there are these cells, and here on the right, we have a 400x image. You can see that there is some fibrosis in here. There's some plasma cells intermixed, and then there are these histiocytic cells that have abundant cytoplasm and very round, enlarged nuclei. Additional IHC was performed, and you can see that on the left, CD163 shows very little staining within these septal infiltrates. And on the right, a higher power view, you can see that the histiocytes look like they're probably reactive. And then these cells with the abundant cytoplasm and the enlarged round nuclei are actually negative for CD163. An S100 stain was again performed, and you can see that these cells show abundant expression of S100. On high power view, you can see both the nuclear and the cytoplasmic staining as expected for these cells. Cyclin D1 was positive in these enlarged nuclei here, and an OCT2 stain shows that there's co-expression of OCT2 in those histiocytic cells, and so this is consistent with a diagnosis of Rosai-Dorfman disease. So a Rosai-Dorfman disease involving the lung is a little bit less common than is ECD involving the lung, with about 10 to 20% of cases. It has a lymphangitic pattern similar to ECD. The other systemic findings in this patient with involvement of lung, skin, sinuses, kidney, and bone can be seen in both diseases. However, the lymphadenopathy seen in this patient maybe is more suggestive that RDD fits better in this case. The phenotype is diagnostic for RDD in this case, as opposed to ECD. The CD163 was negative, and in our experience, This can happen in about 10% of the cases. And then they're also positive, as we've seen for S100, cyclin D1 and OCT2. Maybe another clue that if the original diagnosis had been made correctly, that might have been a clue that the urine cell-free DNA study was incorrect, because BRAF V600E mutations are very rare in RDT. And subsequent plasma cell-free DNA in this case was negative for the BRAF V600E. So I'm welcome any questions that you may have.
Thank you, Dr. Rech and Dr. Picasic, for a wonderful presentation. My question is, isolated CNS JXG and versus isolated CNS ECD, at what age do you draw the line? In other words, at 50 years of age, do I call a patient with a CNS xanthogranulomatosis lesion with positive BRAF as CNS ECD? Should I call the same patient with the same profile at 16 years as CNS JXG?
I have a simple answer. As a pathologist, I hardly ever call anything ECD on the diagnostic line. That's up to you guys. I see what I can see under the microscope and tell you what I see. And I think that that's an important, as we highlighted in some of the cases, to me, ECD is a combination of some xanthogranuloma family lesion look under the microscope. It does, and it is helpful for us to correlate with the molecular, but there is a clinical radiographic that you guys have to define and say to us, this is when I'm going to call it ECD versus the others. So I always teach the pathologists that you can talk about it in the note, but I never, as a pathologist, make that diagnosis. And even with the other histiocytosis, you still have to always correlate with clinical and radiographic findings for all of these.
As a follow-up to my clinical colleagues here, so does it matter to you? I mean, in terms of treatment, you're going to be treating with mutation-directed therapy here, but does it matter to you when I call something as CNS JXG and CNS ECD? At what age do you define a CNX? Do you draw the line?
From my perspective, the kids who have what I would call pure JXG, could be of just about any age, don't have the BRAF mutation. So that makes it a lot easier. And they do respond very well to clofiramine. And I think the BRAF puts them into such a different category of just poor response, so needing combination therapy. So I think you've got to put all the pieces together, like Jennifer said.
Yeah, I can answer also on behalf of a sort of study group, because we collected a series of 21 patients with pediatric ECD. And of course, we had and Jennifer is included in the study. And of course, we had a hard time in defining what ECD is and how to differentiate from other related conditions. And I think we didn't really count on the histological appearance or on the presence of mutations, but rather on typical ECD findings, like there were, I think, 4 or 5 key items. The first was bilateral osteosclerotic lesions. The second was the hairy kidney appearance on CT scan. The third, the typical cardiac involvement, and large xanthelasma as well. And this was on top of a histological diagnosis of a histiocytosis with foamy histiocytes, or with histiocytes that were compatible. So this is a little bit different from previous approaches, which mainly relied on the presence of a mutation. I can tell you that most of our patients were mutated, but generally the definition that we gave, and this was a consensus between some of us, there was Julien, there was also Jean Donadieu with a large experience in LCH, Jean-François Emile as a pathologist. So we met and we decided to have this stringent clinical criteria. I don't know if we are right or wrong, but that's the approach that we followed.
Yeah, I think we are forming a nice question for our 3 p.m. Meet the Expert session. You know, what is ECD? What do we call ECD, and how we knew it in 1930 as it was first described? And there's a lot of, you know, questions that have been brought up today that are very important. You know, is it time to move beyond like just calling the disease by that name, or and future being the molecular aspects?
Thank you. From a nephrologist, I've noticed that you do IHC for 163, CD 163, and some for 68, and some for both. What are the distinction?
Yes, so CD68, we've had that available for a lot longer time period than we've had antibodies for CD163 to use in clinical specimens. CD68 is a protein that is definitely expressed in histiocytes, but it also can be expressed in other cells, and so it is not as specific as CD163. So certain certain cells, so you know, as in so in ECD, CD163 is always positive, as is CD68. In Rosai-Dorfman, CD68 is positive. CD163 is positive in 90%, but it can be negative in 10%. In LCH, CD68 is positive, but CD163 is negative generally in most cases. So there is a little bit of difference in terms of the expression in different lineages, histocytic lineages. I don't use CD68 much because of its non-specificity. It's also difficult to interpret because it has more of a lysosomal staining pattern, which gives it a granular cytoplasmic staining. It can be more difficult to tell if it's true staining, because sometimes you see non-specific granular background in IHC. And also it can be more difficult to tell which cell is expressing it, because the CD163 staining gives a more uniform pattern throughout the cytoplasm, and you can see it directly around, you can see which nucleus it's associated with. So I generally perform the 163, but I don't perform the CD68.
In my practice, I like doing all of the stains, not so much if it's brown or not, but the pattern of expression. So in LCH, for example, the CD68 will have more of a dot-like staining pattern. So I sometimes use the CD68 as a sort of not so much a dual stain, but I use it for how is it staining. So in phagocytic macrophages, for example, it'll be much more dark granular staining, whereas in JXG, it'll have a more light granular staining, and then in LCH have that more dot-like staining. So I have cases sometimes where the immunophenotype isn't fitting exactly well, but I know that there's some S100 and a dot-like staining for the CD68, so it's more of a dendritic type pattern. So it's more than just, is this brown or not? It's the cell type, it's the pattern of expression, it's you know, where is it located? So there's a lot of factors that go into just whether you use it or not, or if it's brown or not.
Well, you know, I do want to take this moment to, you know, thank our pathology experts, you know, the histophiles, I guess, as you called it, Jen. And I think sometimes their efforts go underappreciated, and, you know, how much difference they make. And as clinicians, we have to see the patient a lot of times. But, you know, I remember, you know, we send slides from all over the country and all over the world for them to review, and the number of hours and the time that goes in to diagnose these cases. And, you know, they're an integral part of the team. So I'd like to recognize our histophile pathologists, as you called it, and, you know, give them a big round of applause for that.